Treating cleft palate speech can feel intimidating, but there are clear evidence-based steps to help you plan treatment confidently. I did recently post a video on assessing cleft palate speech, so if you missed that, you may want to go back and watch it. This video will cover practical treatment tips, everything from choosing targets to using tactile cues, plus when to refer to the craniofacial team. I'm Allison. I am an SLPA and a mom to a cleft-affected child. I know this is a super niche area of speech pathology, so I want to make sure that you have the proper tools and information to treat cleft palate speech, as well as the ability to understand the unique speech characteristics of this population. First off, let's get into deciding treatment. When you're planning treatment, the first step is deciding what speech and resonance concerns there are. This is going to help you decide if you start speech therapy, you refer out to the craniofacial team, or both. If you hear compensatory and/or developmental errors, start speech therapy for these errors. If you're hearing compensatory and/or developmental errors plus hypernasality or nasal emission, start therapy for the errors, but then also refer to the craniofacial team. If you're only hearing hypernasality or nasal emission, refer for a resonance evaluation. If there's true hypernasality or nasal emission, this indicates or signals a structural anatomical deficit. Speech therapy cannot correct this. I do get questions quite often about how to treat hypernasality. So remember, speech therapy cannot treat velopharyngeal insufficiency, and oftentimes, unfortunately, it does require surgery to manage. Keep in mind that intervention may be warranted after surgery due to any type of velopharyngeal mislearning, those compensatory errors like glottal stops, nasal fricatives, because speech therapy can correct that placement, that motor planning, that airflow. Let's now talk about a generic treatment timeline. Obviously, this timeline is variable depending on multiple factors, including when surgeries are performed. But first off, let's talk about those younger kids, ages 0 to 3, or what we like to call early intervention. We really want to concentrate on the quantity of language. So our goals are going to be to increase consonant inventory, expand vocabulary, and build oral airflow awareness. This is a critical time period. It is for all kids, but within the context of cleft-affected kids, being proactive with early intervention is going to help us eliminate the possibility of future errors from occurring, those compensatory errors. And then it's also just going to help us improve overall speech intelligibility. Part of speech therapy does involve teaching correct motor movements and airflow patterns that can help prevent future errors. Research has shown that speech therapy can be helpful before errors develop, and that is because we are teaching the placement and the airflow and the motor patterns. When we get past age 3, our focus goes from quantity to quality of speech and resonance. We want to evaluate speech and velopharyngeal function and refer to the craniofacial specialist if needed. From there, we can either begin speech therapy or surgery is considered. It is important to start therapy immediately to address any speech errors. It is a whole lot harder to address speech errors or concerns if they are established errors. Another thing to note is developmental errors that persist to the age of about 5 are much more likely to contribute to the likelihood of other delays. Over half of cleft-affected children will need speech therapy at some point. However, most will develop normal speech by age 5 if they receive appropriate team care and support. Typically, therapy for ages 5 and up is for addressing articulation errors that are residual compensatory errors from velopharyngeal insufficiency, or they can be errors from dental malocclusions. So these errors can either be compensatory, learned, or obligatory, which are passive. Please keep in mind that a lack of growth in a child's phonetic inventory or the persistence of glottal stops or nasal substitutions must be monitored closely. These may be signs of velopharyngeal dysfunction, which will need to be managed by the craniofacial team. They can also be signs of learned misarticulations, which then are appropriate to be treated in speech therapy. But it is critical that you as the clinician are keeping an ear out, you have an understanding of cleft speech characteristics, and you're monitoring them so then you can treat appropriately. When deciding which sounds to target in therapy, I like to look at two main aspects: stimulability and then impact on speech intelligibility. When you're looking at that intelligibility, don't overlook phonology, because if a child is presenting with a phonological error like final consonant deletion, that might have a greater impact on clarity than an articulation error will. Children affected by a cleft palate have been described as having articulatory deficits with associated phonological consequences. So choose whether a phonological or articulation approach fits best based on the number and types of errors you see. Start with voiceless cognates before adding voicing. You want to choose your target words that only have the one high pressure consonant in them, which is your target sound. So let's say you are working with T. Toe would be a great target word. Tomato would work. Tiger would not work because you have the G, which is another high pressure sound that is not your target sound. That way you isolate the new skill without adding other pressure consonants in the word that can cause nasal emissions or glottal substitutions. Once that's mastered, go ahead and pull out your normal articulation word list, your articulation cards that have more than one high pressure consonant sound in them. When you're choosing your targets and approach, remember to pick stimulable sounds, choose what has a high impact on intelligibility, don't overlook phonology, and then target voiceless cognates before voiced. Next, let's talk about establishing correct placement and using tactile feedback. Use previously acquired sounds to establish placement. For example, if the child can produce M, use that to shape B. You do want to focus on correct placement before you change anything else, before you go and change the manner or voicing, just to help minimize confusion for your student. Use tactile feedback to help them feel correct placement. This builds new motor patterns and awareness much faster than verbal instruction alone. Have the child touch their neck to feel for inappropriate glottal activity, or place a finger beside the nose to detect nasal vibration during fricatives. Feeling a puff of air on the hand during plosives or using gentle nasal occlusion can increase awareness of oral flow and pressure. These cues help reinforce the difference between oral and nasal resonance and promote correct sound production. You want to obtain 100% mastery of the target sound in isolation before you move up that typical articulation hierarchy. In terms of treatment intensity, you want to schedule high frequency sessions. I know that can be tricky, but at a minimum, 1 hour a week, or you could even do 2 30-minute sessions a week at a minimum. And then in your sessions, you are aiming for high repetitions. If progress stalls over 4 or 5 sessions, this might signal the need for a new approach or a new target. Also, be sure to establish an at-home program for the child so they can use their target sounds and implement them into everyday conversation and speech. It's important to note that non-speech oral motor exercises, things like blowing bubbles, blowing horns, lip stretching, whistling, these are not effective in treating speech sound errors, even in children with cleft palate. Non-speech oral motor exercises do not strengthen the palate for velopharyngeal closure. They don't improve articulation or reduce or eliminate nasal air emissions. Speech develops through speech. So instead of non-speech tasks, use those tactile cues we talked about during production to guide correct placement. And lastly, again, if you suspect velopharyngeal insufficiency, refer the child to a craniofacial team. We're at the end. So to wrap up, here are the main takeaways. Treat compensatory errors first. Be sure to refer for resonance when needed. Choose targets that improve intelligibility. Use tactile and placement cues, not non-speech oral motor exercises. And then lastly, aim for high frequency and carryover. I created a resource specifically for treating cleft palate speech. It includes specific treatment tips, cleft-specific articulation word lists, strategies for teaching compensatory errors, and a whole lot more. This is a comprehensive guidebook that includes a wide variety of treatment strategies, handouts, and visuals to use in speech intervention. You'll find articulation activities for high-pressure consonants, information to understand compensatory errors and how to remediate them, as well as everything you need to know for resonance and nasal airflow. I also have a topic page on my website, AllisonForce.com, with even more information on this topic. It has tons of links to websites, books, professional development, blog posts I've written, all about treating and assessing cleft palate speech. So be sure to visit it here. Thank you so much for watching this video. I hope you found it helpful, and be sure to catch my other videos on cleft palate speech.